Hi guys, welcome to the regional circulations lesson in the vital fluids block. We're going to talk a little bit in this lesson about special characteristics of the circulation in different regions of the body. And we're going to particularly concentrate in at least some cases upon how those special characteristics correlate with what you see in congestive heart failure. Which is, of course, why we teach the vast majority of them. It won't be restricted to that, but you will notice there's a definite trend. So having said that, let's get started. First of all, a little general overview of the circulation just to get us up and running. As you guys know, we have our heart here, and we have our right ventricle in our heart. And everything that comes out of the right heart enters the pulmonary circulation. So we say that these two are in series with one another. So if the output here is 5 liters per minute, 5 liters per minute goes to the circulatory, the pulmonary circulation, and then 5 liters per minute is returned to the left heart. So these are all in series with one another, okay? And then our blood leaves our left ventricle. It perfuses our circulatory beds and the various organs around the body, and then the blood is returned to the right ventricle, So your cardiovascular system is tuned to maintain mean arterial pressure because your body is smart enough to know that nothing flows unless there's a pressure difference across the system. So you have to maintain high arterial pressure if you want these beds to be circulated. And so what you will do, of course, is you will change heart rate and stroke volume and total peripheral resistance in order to keep mean arterial pressure as close to constant as possible. And you do that, of course, in part by regulating the output from the heart, and we've talked about that. But you also do it by regulating the resistance of flow to the beds. And so the total peripheral resistance is altered to keep that mean arterial pressure high. In addition to that, you have flow to these regional beds that has to be regulated in order to match the respective metabolism in all the beds. So if regional circulation 1 is very active and needs a bunch of blood, it needs to be able to get it, whereas regional circulation 2, maybe it's not active, it doesn't need to get as much. So individually, these beds are regulated as well as being regulated as a whole by your baroreflex and by your reflex systems. We'll talk more about reflexes in the next lecture. For this lecture, we're going to talk a lot about how this regulation takes place locally to assure that blood flow takes place to get the beds that need oxygen and metabolites when they need it. All right, so we have a lot of different regulators of blood flow, and you were introduced to this in a very early lesson, the structure and function of the cardiovascular system. But just to review, we have basal tone, which is smooth muscle. It maintains tone no matter what. It's probably largely myogenic. You have local tissue chemical modifiers, primarily metabolic modifiers. These play a big role, for instance, in exercise and under other conditions where metabolites will build and you'll get vasodilation in order to make sure blood flow takes place to the tissue when it needs it. We have autoregulation. Remember, this is qualitatively in all of the circulatory beds, but it's far and away the most important in the renal system, where the smooth muscle will automatically constrict and dilate in order to keep flow constant over a given range of blood pressures. We have active hyperemia, increased blood flow caused by enhanced tissue activity, probably mostly by modification through these metabolic modifiers. So this would be, I exercise, my skeletal muscle gets more blood because I'm using more oxygen and more metabolites. That's active hyperemia, increased flow to active tissue. Reactive hyperemia is a little bit different. That's increased blood flow to an area after release of an occlusion. So the most obvious example of this would be your coronary artery. It's blocked, the tissues downstream aren't getting much in the way of oxygen, you unblock it, and there's this automatic huge increase in flow to the area due to the fact that while it was blocked, a bunch of metabolites and local modifiers built up. And then you release that occlusion and all those modifiers are there and you're just getting an increase in flow to the area. So that's reactive hyperemia. We also have exogenous regulation, the autonomic nervous system, the big one, right? Mostly sympathetic and cholinergic, not as common, some rare instances where parasympathetic will be involved. But generally speaking, output to the blood vessels is entirely sympathetic. Sometimes you get sympathetic cholinergic, meaning sympathetic fibers release acetylcholine. And on rare occasions, in selected places, you might see a parasympathetic innervation, but not common. And then we have other vasoactive materials, endothelin, angiotensin, vasopressin. These will come up as you move through your lessons. You may hear a little bit from me, particularly when we get in the renal section. You'll probably hear a lot in pharmacology as well. Okay. So, this is a table, and I'm going to walk you through it. There's a lot of columns here, but it does sort of make a point. So let's start with all of these tissues, all these organs here on the right-hand side. And we have this column here, which is oxygen uptake in mils per 100 grams of tissue per minute. So this gives you an idea of how active the tissue is in terms of how much ATP it eats up, because oxygen consumption would be proportional to that. So we have our splanchnic beds, which have 2 mils per 100 grams per minute. Notice that our kidney tissues are more active, and that would make sense. There's a lot of active transport going on in the kidney, and we'll go into this into enormous detail when we do the kidney in future lessons. The coronaries eat up a lot of oxygen. The heart, a very active tissue, always beating, right? On the other hand, skeletal muscle at rest doesn't really eat up much ATP. If it's not contracting, there isn't much to supply there. Skin doesn't eat up a whole lot per 100 grams of tissue, okay? So that's an indication of the metabolic rate of the tissue itself. Now you'll notice that the number changes when instead of we say per 100 grams, we just say into the organ. So the splanchnic beds are sort of like your intestines and your liver and such. There's a lot of weight there. I mean, and so because there's a lot of tissue that you're perfusing, you have a fairly high 58 mils per minute going to your GI tract and your splanchnic beds, even though the tissue not really that active, right? The same thing with skin, 5, pretty high when you consider the fact that the metabolism of the skin itself is relatively low, and a large of that is due to its weight. A large part of it is due to the weight, okay? So if you take that into account for it, you get a percentage of the total oxygen consumption for each of these organs. So GI tract, a relatively high 5, renal, a relatively low 7, despite the fact that its metabolic rate per 100 grams of tissue is pretty high. That's because your kidneys don't weigh nearly as much as your GI tract does, okay? And so these are the percentages. Now in an ideal world, what you would do is you would match the cardiac output. So that 25% of the cardiac output, meaning 25% of the total oxygen being transported in the blood, would go to the splanchnic beds. 7% would go to the kidneys. 30% would go to skeletal muscle, okay? But in reality, it doesn't quite work that way. The percentage of cardiac output varies quite a bit, but it doesn't always completely match the oxygen uptake. when you consider just metabolism alone. And so the reason for that is because a lot of these organs use oxygen for something other than metabolism. So if the kidney got just what it needed based upon its metabolism, that is the amount of oxygen it's utilizing, 7% of the cardiac output would be enough. But it doesn't get 7%, it gets 19%. And so we call organs like the kidney, we say that they are overperfused, okay? And that means that they get more than you would predict based upon their metabolic rates. And in the case of the kidney, that should make sense to you. Your kidneys generate urine. They have another function that goes beyond metabolism, and so they need to get a lot of blood so they can generate urine and get rid of waste. So a lot of that blood is going in there, and it's not being utilized by the kidney tissue. It's just there so that you can generate urine because you need volume there in order to get rid of the waste. The same thing is true of the skin. The skin, in terms of its metabolic rate, doesn't really require that much oxygen, but it gets a lot more blood than that. And as you're going to find out later on in this lesson, that's because it's involved in temperature regulation. Okay? So we have a lot of tissue. We have tissues that are like that. The most classic ones are the kidney and the skin, where you have a function that requires that organ get blood for some reason other than just its metabolism. Okay? These tend to have a low AVO2 difference. That means if you measure the amount of oxygen in the arterial blood going in, you measure the amount of oxygen in the venous blood going out, and you take the difference between the two, that difference tends to be low in overperfused tissues. So in the kidney, it's like 1.3. In the skin, it's like 1. And you can compare that to the coronaries where it's like 11.4. And the reason for that is there's a lot of oxygen left over in the venous blood when they exit these tissue beds, because not that much oxygen is being taken up and utilized. That blood went in there for some other reason. Okay? Now, on the other hand, you have some tissues that don't get as much blood as you would expect. The classic examples really probably wouldn't make a whole lot of sense to you, but they are actually the brain, which by its metabolism would demand 20% of the oxygen, but only gets 13% of the cardiac output at rest. The coronaries, you would think, man, that should be overperfused, right? I mean, shouldn't that be getting more blood than it needs, if anything? Who's going anywhere without a heart? Well, if you went by oxygen demand, it should get 11% of the blood. It doesn't. It only gets about 4, okay? And the reason why organs like this at rest don't get the cardiac output that you would predict that they would need based upon their metabolism is because they tend to be very well, the flow to those beds tends to be very well regulated. Okay, and so these beds, your heart and your brain, when they demand oxygen, when they demand blood, they get it. Your body is tuned to make sure that they get it, and because of that, your body thinks, well, there's no reason to give them a whole lot at rest, because when they need that blood, I'm tuned to make sure that heart and the brain, they get that blood. Okay, so because of that, they don't get an excessive amount of blood at rest, but when they need it, they get it. We call tissues like this underperfused. That is a very, very unfortunate term because it suggests that these tissues don't get enough blood. You say they're underperfused, that means they're not getting enough oxygen. That is not the case. They are getting enough oxygen. They just aren't getting a whole lot more than they really need at the baseline, because when they demand more, they get it. Your body is tuned to make sure they get it, and so at rest, when they're not demanding it, your body says, okay, well, we can allow that to be a little bit lower than you might expect. These tissues tend to have a high AVO2 difference because a high percentage of the oxygen that's going in through the arterial blood gets used by the tissue, and what's left over in the venous blood is a relatively low amount. So the AVO2 difference for coronaries, for the brain, tends to be relatively high because you eat up a lot of oxygen. Skeletal muscle is another one that's relatively underperfused and relatively high AVO2 difference. Your body is tuned to give skeletal muscle oxygen when it needs it. The local metabolites build, you get vasodilation, it gets it, okay? So there isn't a whole lot of reason to give it a whole lot of excess at rest, okay? All right, one thing that I would emphasize to you, you see underperfused here for skeletal muscle, and you think, you know, that means that it doesn't get enough oxygen. But the heart in particular is really bad for this. I'll ask students, okay, you know, when you exercise, I'll say, is there enough oxygen going to your heart? And the answer is yes. Of course, it's yes. Your heart gets enough blood when you exercise, okay? It does. It's just that the blood flow is relatively low at rest because when it demands it, it gets it, okay? All right. So don't try to tell me your heart doesn't get enough blood when you exercise. That would be a very bad thing to answer on an exam. I'm very disappointing. All right. That's all I've got for this first video in this lesson. We'll proceed on to the next video when you're ready. Thank you for your attention.